Welcome to the first lecture of our 2017-2018 series, Medicine in Our Backyard. I'm Susan Grew, and I am the Programs Director for the Newport Beach Public Library Foundation, and this is a Foundation program series. Did you all know that increasing your understanding about health issues can actually both improve the quality of your life and also extend it? With this informative series, the Foundation is proud to help make the members of our community both healthier and happier by informing them. Now, we ask that you please return the favor. We need your help in maintaining the health and happiness of the Foundation by becoming a member. Sometime tonight, please be sure to visit the back of the room and pick up a copy of our newsletter, which has a picture of the Pulitzer Prize-winning author Colson Whitehead on it. His appearance here at the library is listed along with many of our other upcoming programs. And while you are looking at all that we have to offer, thanks to the support of our members, please fill out the enclosed membership application and join their ranks. We cannot do what we do without you, the members. Thank you all existing members, and welcome to our new members to our informative and stimulating program season. Tonight, we would especially like to thank our Medicine in Our Backyard series sponsors, Dr. Ike Kempler and Ginny Kempler. We would also like to thank UCI Health for their partnership in bringing their extraordinary group of doctors here to the Newport Beach Public Library. This series will continue on through May. Next month's lecture is on October 23rd, and the topic will be men's health issues. But first, I am pleased to introduce Dr. Ruth Benca. Dr. Benca is the chair of the UC Irvine Health Department of Psychiatry and Behavioral Health. She is a board-certified neurologist and psychiatrist and is an internationally recognized authority on the relationship between sleep and psychiatric disorders. Dr. Benca has also served as president of the Sleep Research Society. Dr. Benca comes from the University of Wisconsin at Madison, where she served as the director of the UW Center for Sleep Medicine and Sleep Research. We are honored to have her here in this library, here in Southern California, and we hope she enjoys our winters very much. Dr. Benca.
Thank you. Thanks. See, is this working? Yep, my microphone's on, because then I can walk around a little bit. Thank you all for coming. I'm really excited to talk to you about sleep. Maybe I'll put some of you to sleep, I hope not. But maybe those of you who stay awake will learn a little bit more about what sleep is and how to take care of it. Sleep is actually, I think, the most fascinating of all of our behaviors. We spend more of our time sleeping than doing any other one thing besides sort of generally being awake. And in the course of our lives, it's estimated that people in the United States, we will spend a little over a third of our lives sleeping in comparison to other things we do. And given that this is a behavior that we spend so much time doing, what's quite interesting about it is we really are not exactly sure why we need to sleep, despite the fact that it keeps us from doing much of anything else productive, which is why I think a lot of people keep trying to shortchange themselves of sleep. So what I want to do today is go over a couple of different topics related to sleep. Again, what sleep is, why we do it, at least as far as we know right now, what happens when we don't sleep enough, and a little bit about some of the common disorders that might affect your sleep, and some tips on how to improve your sleep. So starting out, let's talk about exactly what sleep is. Sleep is a kind of a difficult behavior to describe because we're not really aware while we're doing it. We can watch other people sleeping. We are aware of when we've been asleep and when we feel tired. Basically, sleep is a state in which we are less responsive to what's going on around us in the environment. We tend to sleep in a typical posture, usually relaxing our anti-gravity muscles, so we're hopefully sleeping in usually in a particular place, our beds. And sleep is a reversible state, so it's not like being in a coma or hibernating, which are states which on the outside may look somewhat similar. We divide sleep up into stages based on brainwave patterns. And so in a sleep laboratory setting, for example, we apply electrodes to the scalp and other parts of the body to sort of measure what's going on in the brain. And without going into too much detail, I'm just going to show you some of the tracings here. So a waking brain looks something like this. The electrical activity that we record off the surface of the scalp is kind of fast. As we fall asleep, what happens is the activity starts to slow down until we get into a very deep stage of sleep here called slow wave sleep. And I think everybody can see that this pattern here looks very different than it does on the top. And there are a couple of sleep waveforms that we're particularly interested in studying these days, since they seem to be partly related to some of the functions of sleep, particularly those related to things like cognitive function or learning and memory. And those are these big slow waves and these little short bursts of fast activity called sleep spindles. Now, these stages of what we call our non-REM sleep or non-rapid eye movement sleep, which become progressively deeper, stages 1, 2, and 3, and they alternate with a stage of sleep called rapid eye movement or REM sleep, which sometimes people call dreaming sleep because we're most likely to be dreaming in REM sleep. But in fact, you can dream in any stage of sleep. And sometimes you'll notice, particularly if you kind of wake up during the night and you're sort of half dozing, you'll find yourself dreaming even before you've totally fallen asleep. Those are stage 1 dreams. And so you really can dream in any stage of sleep. You just have the most vivid and sort of hallucinatory dreams in REM sleep. There are a couple of other interesting features of sleep, which I'm going to talk about once we talk about what a normal sleep pattern looks like. So in a normal, healthy adult who is sleeping at a regular time at night, it usually should take about 15 minutes or less to fall asleep from the time you really sort of turn everything off, shut off the lights, and close your eyes and relax. And then you progressively go through deeper stages of sleep. You see here it goes to 4 because we used to divide non-REM sleep up into 4 levels. Now we just use 3 levels. But you have your deepest non-REM sleep at the beginning of the night. And then you cycle back and forth across the night between episodes of non-REM sleep and REM sleep or dreaming sleep. And there are a couple of important patterns across the night. The first is that you have your deepest non-REM sleep, your most slow wave sleep at the beginning of the night, which is why those first few hours of sleep often feel like you're really out or you're sleeping pretty deeply. And as the night goes on, your sleep progressively gets a little bit lighter and not quite as deep. The other trend is that your REM sleep episodes get longer and more intense as the night goes on. So your dreams in the early morning before you wake up are usually longer and more intense, and they can go on for a half hour or more. Another thing about REM sleep is that there are changes in our physiology when we're in REM sleep. One of the things that's quite notable is that we're actually paralyzed, or we're supposed to be paralyzed in REM sleep. And so sometimes you'll have dreams that you're trying to get away from something and your legs feel like lead and you can't move. And that's because you really are paralyzed and your brain is somewhat aware of that. If you fail to be paralyzed in REM sleep, you can start violently acting out dreams, and that's actually a sleep disorder that we call REM sleep behavior disorder. You're supposed to remain paralyzed when you're in REM sleep. The other thing that happens in REM sleep is our autonomic nervous system that is controlling things like our heart rate and our blood pressure and our breathing rate become very unstable. So that REM sleep is a time of night when people are more susceptible to things like heart arrhythmias and other problems with cardiac function or even breathing problems. And people who have breathing disorders can get into more trouble in REM sleep. Yeah.
REM, do you actually mean rapid eye movement?
Rapid eye movement.
Literally what that.
Right, because that's the other thing about the state of REM sleep is because your eyes are moving rapidly. The only muscles in your body that aren't basically paralyzed in REM sleep are the muscles that control eye movements and your diaphragm so that you can keep breathing and don't suffocate, but the rest of your muscles are generally paralyzed. Your eyes are not moving in non-REM sleep, and some studies have suggested that the eye movements in REM sleep are somewhat related to the visual components of your dreaming. All right, so the thing that has the biggest influence on our sleep patterns is our age. We start sleeping before we're born, and we sleep throughout our lives. This is kind of a diagram that shows how much and what kind of sleep we have. But what I want to point out is that although this starts basically at birth and goes to age 90, this is not a linear pattern here. This is age 30 right here. So sleep changes most dramatically during early development and young adulthood. And sleep is actually an exquisitely sensitive window on brain development. I'm going to show you that in just a moment. And in fact, the human brain doesn't finish developing until the mid to late 20s. So sleep patterns don't become fully adult-like until the middle of the third decade of life. And then there's a period of stability, and then as we get older, we tend to get less sleep. The other thing is that, of course, a newborn will spend about 2/3 of the day sleeping, so they're flipped. You know, in adulthood, we're spending about 1/3 of our time sleeping. Babies are spending only about 1/3 of their time awake, and they have a lot of REM sleep, and young children do too. REM sleep, or dreaming sleep, is actually a very activated time for the brain. In fact, the brain is potentially more active in REM sleep than it is during waking, which sort of discounts the idea that the sleep is a time that your brain shuts off. Actually, nothing could be farther from the truth. But as we get older, we start to lose our REM sleep. We spend less time sleeping overall, and we may spend more time in bed to get less sleep because our sleep becomes less efficient. We tend to wake up more at night. What we don't know is whether this decrease in sleep as we get older is because we need less sleep or we're less able to sleep, and it's probably a little bit of both. And the other thing that happens, of course, as we get older is we develop more other kinds of medical problems or even more depression or other things that can interfere with sleep. So there's a lot of things going on that unfortunately interfere with sleep as we age. One of the things that we did when I was in Wisconsin, and which we will plan to do here in Irvine at UCI when we get our sleep lab up and going shortly, is that we actually use sleep as a way to image the brain. And those of us who study sleep actually think that the best way to look at brain function is while someone is asleep rather than when they're awake, because when we're asleep, our brains are all sort of like a car engine idling. We don't have the confounds that, what we're thinking about or that we're making an effort to do something or attending or not attending. And again, some of these basic waveforms of the brain only appear during sleep, some of the important ones functionally. And we can look at sleep from the youngest infants to older individuals in a very safe way. Before I showed you these sort of squiggly EEG tracings, which represent the activity from one electrode on the scalp. And I think one of the things that we've started to understand more recently is that although there's sort of a global aspect to sleep, we're asleep or we're awake, we're in non-REM sleep or in REM sleep, the fact is that the brain sleeps differently in different parts of the brain. And it's not necessarily doing the same thing all over the brain. And I'm just going to show you here these two important waveforms that we've talked about, slow waves before and very deep sleep. Again, slow waves are only seen in sleep. And slow waves are probably related to what we call brain plasticity, the ability of your brain to learn new things. And they're related to how actively your brain is changing during the daytime. And slow waves are most prominent in the prefrontal cortex, the front part of the brain, which is the part of the brain that's important for a lot of our higher cortical function, our executive functions, our sort of consciousness and you know, a lot of our learning aspects. Sleep spindles, which are now also are known to be very important for certain aspects of learning, sleep-related learning as well, are most prominent on the top of the scalp here because they come from a particular structure in the brain that is closest to this part of the scalp where we're recording electrodes. So we now start to look at sleep patterns all over the surface of the brain. And as I go through and talk about some different kinds of problems that occur with sleep, I'm going to start showing you some pictures of how these topographic patterns on the brain change in different types of sleep problems. Okay, so now let's, look using this technique about, what happens in the brain across development and aging. And again, sleep is measuring sleep because when we do sleep recordings, it's absolutely safe. There's no x-rays, no needles, no drugs or anything we used. We're just passively recording electrical activity. So here's what sleep looks like across early development. So this is these are sort of averages of groups of kids that are healthy and normal. So this is 2 to 5-year-olds, 5 to 8, 8 to 11, and so on until we get to 17 to 20-year-olds, so sort of older adolescents. And red means more activity and blue means less activity. And this is slow wave activity, which I just told you before is most prominent in the front of the brain, but that's when you're an adult. In children, it's most prominent at the back of the brain, and that's because the brain is developing from back to front. And the frontal sort of full development of the brain that is important for things like impulse control, et cetera, does not really fully develop again until the 20s, which is why adolescents are not always good at judgment because their brain isn't fully developed yet. But this is sort of a really interesting way that we can look functionally at how the brain is developing. One of the things that we looked at in my lab was what happens as we age, because we know, sleep amounts change. What's happening to the pattern on the surface of the brain? Now, this is a little different kind of a picture than I just showed you. This is basically showing over time from the age of 18 to 65, how are things changing in terms of those slow waves, which I talked to you about before, those important deep waves, and the sleep spindles. And we look sort of across the whole scalp. And what happens is, as we get older, across our entire brain surface, we lose slow waves. We're not making as many slow waves because, unfortunately, we're losing neurons. That's why we have to get kind of more clever since we, and use our experience since we're losing some of those brain cells. The other thing that happens is we tend to lose spindles, particularly spindles in sort of the kind of more front half of where spindles appear. And these spindles are very important for cognitive function. So this is one of the reasons that we don't feel quite as sharp as we get older, separately from any kinds of neurodegenerative disorders, is that we're preferentially losing not only neurons, but our sleep is showing the evidence of these changes in our brain activity. So that's kind of what sleep is and how it changes. Let's talk a little bit about why we sleep. And again, I think this is one of the most interesting mysteries in biology, is not only why we sleep, but why all living creatures that have been studied sleep. Anything with a neuron sleeps. So they've just been shown studies definitively this year that roundworms sleep. We know flies sleep. Pretty much everything sleeps. And some people argue maybe even plants sleep, but we won't quite get into that today. Let's talk a little bit about why we sleep. So My colleagues in Wisconsin, Giulio Tononi and Chiara Cirelli, not too long ago put forth a hypothesis that sleep is what helps our brains be plastic. So sleep is the price we pay so that we can learn and our brains can change day to day. So what happens, these are sort of a picture of neurons, and neurons in our brain consist of cell bodies that are connected to each other by these projections, axons and dendrites that hook together. When they touch each other, they form a synapse. And this connectivity of neurons in our brain is how information gets sort of transferred and stored. And while we're awake during the day, whether we think we're learning things or not, we're learning things. We're experiencing things. And those synapses, let's see how this goes. I'm missing a slide, but I'm going to show you this. The synapses sort of grow and get bigger. So we get stronger synapses and we grow more synapses. So at the end of the day, if you've been awake and interacting with the environment, your brain is different than it was in the morning, and consequently the following morning it's going to be different again, because again, we're learning all the time while we're awake. Oh yes, and there they are. The synapses are getting stronger. So some synapses, the ones we're using, are selectively getting stronger. And the problem is that we can't just keep growing synapses. What if we were just awake all the time and growing new synapses and strengthening synapses? We'd run into a couple of problems, one of which is that the brain would require more energy. They would require more space. You know, our skull only will hold so much tissue in there, and if we keep growing things, it won't fit. And there's also sort of a signal-to-noise ratio. If you've got all these connections, it's really hard to organize things, and plus it takes more energy. And the strength, finally, you can't make things any stronger. So what happens is that overnight, we have a process of synaptic pruning. So we grow more synapses during the day, we get rid of some of them at night. And many studies done in both animals and humans have demonstrated that after a night of sleep, we have smaller and less numerous synapses than we did right before we went to bed, although some synapses are also strengthened. So sleep, people sort of want to argue, is sleep for forgetting or remembering, and it's both. We sleep to forget and we sleep to remember. But the idea is our brains are constantly changing because of that, and most of these processes that are important in terms of learning and memory take place in sleep. That's why you don't really remember anything that happens while you're sleeping. You don't remember your dreams. You don't remember what your brain is thinking about, because you can only remember things that you put into memory storage while you're awake. Now, another thing we've learned about sleep in recent years, and this is the work of Dr. Nedergaard in New York, is that sleep is also for what we call brainwashing. So she did this very elegant experiment where she was able to image the brain of a living mouse, a sleeping mouse, during sleep and wake. And this is a blood vessel running through the brain, and this is sort of the space around the blood vessel and in between the cells in a sleeping mouse versus an awake mouse, and you can see it's a lot bigger here. And what she demonstrated is that during sleep, the cerebrospinal fluid that our brain sits in washes through the tissue of the brain and is eliminating stuff that shouldn't be there, such as some of the proteins that seem to be involved in the development of Alzheimer's disease, like beta amyloid and tau. And studies done in humans show that in normal, healthy humans, most of the beta amyloid removed from the brain is removed during sleep. So it's another function of sleep. Now, these are not probably the only functions. Again, we're spending a third of our lives doing this. And it also, you know, we are starting to get evidence that sleep is important for the rest of our body, not just our brain. But I think these are two of probably the most seminal findings recently in terms of starting to understand, you know, why we spend so much of our life sleeping. Okay, so what happens when we don't sleep enough if we're sleep deprived. And unfortunately, as a society, we are sleep deprived. I think in the United States and probably many industrialized societies, we have decreased our total sleep amount almost 20% over the last 50 years or so. And it's not that we've evolved that we suddenly need less sleep, but we just have now a 24-hour society, and it's really easy not to sleep. I mean, a lot of you probably also still remember, like I do, that years ago, television, there was no television broadcast after, 9 or 10 o'clock at night, and it didn't come on until the early morning. I once found one of those, the signs they would have on the TV saying, nothing's on, we're all asleep right now. So when we don't sleep, when we have an acute episode of sleep loss, like we have a really bad night of sleep, or we don't let ourselves sleep enough and have to get up early for something, a lot of things will start to happen, which is our attentional abilities are decreased. We can't stay on task. Our working memory, our ability to hold, several ideas at once in our head, or, have several dishes cooking on the stove at once, or however you want to think about working memory, doesn't work as well. Our innovative or creative thinking isn't as good. We have word finding difficulties. We don't control our behavior quite as well. We start doing more risk-taking behavior, and we lose our sense of humor. So lots of bad stuff happens to our not only our cognitive but also our emotional function. We've learned, studying people in high-risk situations like physicians, particularly physicians in training, that when they have to work very long shifts on call, they make more errors. They make diagnostic errors, et cetera, when they have to work longer than 16 hours. And in fact, most studies show that after being awake for about 16 hours, you start to have lapses in your attention, and your whole ability to function starts to break down a bit. And of course, that led to some new regulations a number of years ago for medical residents, again, who are less experienced, which means that they're more likely to make errors, that limited shift work in numbers of hours per week. Now we're sort of going back on that a little bit, but the fact is that sleep-deprived doctors don't do as well as ones that are sleeping properly. Even more, or just as great concern to the public at large is what happens in the transportation industry. So at least, I think this is an underestimate, at least 10 to 15% of fatal vehicle crashes are related to sleep deprivation or sleep-related factors. Truck drivers are now limited to driving only 70 hours a week. And there's been some very dramatic cases of sort of big disasters over the years: the Exxon Valdez crash, the Chernobyl meltdown, the 3 Mile Island meltdown, nuclear reactor meltdowns, all attributed to people who were basically asleep at the wheel. Other things that we've learned, though, about sleep is that long-term or chronic sleep loss is not good for people either. And sort of the final common endpoint is that many epidemiologic studies that have looked at sort of how long people's average sleep is that people who sleep less than an average of 6 to 7 hours per night have an increased rate of dying, controlling for many other risk factors. We also know that people who chronically don't sleep sufficiently are at increased risks for developing hypertension, diabetes, and obesity. Because one of the first things that happens when you don't sleep enough is that the neuroendocrine systems and brain systems that are involved in eating cause you to want to eat more food and more high-calorie, high-reward food. All right, so now we've talked a little bit about just sort of the general effects of sleep loss and the importance of sleep. What are some of the common sleep disorders, and how do they affect sleep? And we'll talk a little bit about what we can do about them as well. And I think probably one of the most common ones, of course, is insomnia, the difficulty falling asleep, could be frequent awakenings during the night, sometimes for prolonged periods of time, waking up earlier than you want to in the morning, feeling somehow that your sleep is not satisfactory. And the other key about this is that it has to lead to some sort of impairment in daytime functioning. Every once in a while I have people come to see me who complain, I'm only getting so many hours of sleep at night, or I'm taking a while to fall asleep, but they feel perfectly fine and they're extremely functional during the daytime, and it really doesn't bother them at all. They're just worried that maybe I'm not getting enough sleep. And again, just to keep in mind that when I say getting less than 6 to 7 hours of sleep is not ideal, there is a bell-shaped curve. There are some people who are shorter sleepers. So if you feel like your sleep is good and you're not impaired during the daytime, it may be fine to be sleeping a little bit less. But most people with insomnia don't just complain that they're not getting enough sleep, but they really feel like their sleep is of very poor quality. And about 10 to 15% of the general population will complain of chronic insomnia that will be affecting them at least a few nights a week for periods of at least 3 months or more. There are a number of risk factors. Obviously, as we get older, we're more likely to have problems with insomnia. Women, particularly post and perimenopausal women, have higher rates of insomnia than men, and that's pretty much true across the lifespan starting in adolescence. Any kind of loss of a significant other is a big stressor that can lead to insomnia. Psychiatric illnesses, medical disorders, the more medical problems people have, the more likely they are to have insomnia. Consumption of certain kinds of substances, cigarettes, nicotine is a stimulant, alcohol, coffee. Alcohol puts you to sleep at night, but then you wake up a couple hours later and may have very fragmented sleep later in the night. And many prescription drugs can affect sleep in various ways. So these are always things to think about. Now, some of the work that we've done with insomnia, again, looking at what's going on in the brain of someone with insomnia, is that this is a comparison of a group of people with insomnia compared to matched controls. And what we see is that there's sort of this strip across the middle where there's a waking brainwave pattern while they're deeply asleep. And this corresponds to some very interesting brain areas that we can map out, including their auditory, so the parts of the brain that control sound perception, visual perception, and some of the sensory motor cortex. So basically a lot of the sensory systems seem to be awake, which we think kind of fits with what a lot of people with insomnia say, is that they can hear every little thing and they feel like they're not really asleep and aware of what's going on. So it does seem like parts of the brain that may be sort of attending to the outside world may be a little less asleep than other parts. We'll talk a little bit later on about what to do about insomnia when we talk about things you can do for your sleep. Another common disorder, again, particularly as we get older, is something called restless legs. Restless legs is an uncomfortable sensation in the legs that is usually described as being indescribable. That's what patients are. I can't describe it to you. It feels like, I just got to move. I've had people say it feels like my skin is turning inside out, or it's itching on the inside, or it's usually, sometimes pain, it's accompanied with pain. It can be painful as well, but not necessarily typically. But the key is that it's always relieved by movement. So in really bad cases, people literally, maybe jump out of bed and walk around, or you're sitting watching TV at night or something, or reading, and you have to get up and move or jiggle your legs. It occurs at rest, and it's worse at night, and it usually goes away in the morning. It can be associated with insomnia because if your legs are uncomfortable, but you've got to wiggle them or move them or get out of bed or stretch them, you're not going to sleep. Again, this is another problem that gets worse as we get older. And it is about twice as common in women, affecting about 10% of women. It's a clinical diagnosis. You don't have to have any kind of a test if you have a careful examination by a physician who knows about restless legs. And is associated with a couple of other kinds of problems, some of which might be treatable, one of which is iron deficiency. And you don't have to be anemic to be iron deficient, so we always check iron. This is also very true in children, because children can have restless legs, and most of the kids I see with restless legs is due to them probably being a bit iron deficient, and sometimes just replacing iron can be helpful. That's why it's more common, particularly in younger women, pregnant women, because the baby's taking all the iron away. Some other things, though: folate deficiency, peripheral neuropathy, kidney failure, which can affect iron balance, and excessive caffeine use can make it worse. There are also a number of drugs that can make restless legs worse, including pretty much almost any antidepressant, antipsychotic drugs, lithium, trazodone, which a lot of people take for sleep, can make it worse. So we treat this in a variety of ways. Obviously, for iron deficiency, we replace iron. We do things like stretching or massage or heat in the evening. And then there are a variety of medications that can also be used to treat this disorder fairly successfully in most cases. Okay, now I want to turn to another very common problem: obstructive sleep apnea. This, sort of the more classic, the wife is awake from the snoring while the husband is lying on his back, snoring up a storm, although sometimes women can be the snorers and have apnea as well. Usually people with apnea are brought in to me by their bed partners, because, the diagnosis is made by the person who can't sleep. And snoring can be like, I'm going to tell a little anecdote. So I'm going to show you in a minute. We're building a beautiful new sleep lab in Newport Beach that's not too far from the airport. And the architects were concerned, and the people at UCI of like, well, what about the airplanes going overhead? And I said, don't worry, we checked the building out. It's really well insulated, and a whole bunch of planes went overhead, and we didn't hear a thing. Plus, of course, they don't let the planes go in and out when people are sleeping at night. But I said, but the big problem you're going to have is not the planes going overhead. It's the snoring of the patients in the room next to each other, because snoring can go up to, and they said, oh, don't worry, we're going to do the high quality insulation. We're going to get it up to 20 to 30 decibels. I said, snoring is 70 to 90 decibels. And so the last sleep lab I built, the architects, probably because I was a female, didn't listen to me. And that was the biggest, I said, the biggest complaint you're going to have is if you don't soundproof it well. So snoring can be quite loud. It can even cause hearing damage to the person snoring or the person listening to the snoring. So what happens in apnea is, and the most common kind of apnea, obstructive apnea, is the back of the airway, just sort of behind the tongue, where the airway is just a little soft sac, collapses. And not surprisingly, that happens when you're lying down, particularly on your back, because gravity's pulling all this shut. And the muscles in the back of our throat as we get older do the same thing as the rest of our muscles. They get a little flabby. And it's the muscles that have to hold this open. So what happens is, instead of being able to pass air back here, you keep trying to breathe, and you can't pull any air in. And the more you, because the person keeps trying to breathe, the more you try to suck air in, it's like putting your finger over a straw and sucking on it, it just collapses even more. So the way that you terminate the apnea or the cessation of breathing is you got to wake up for a few seconds, which kind of sort of almost like a startle. The airway opens, you can take a few gasps, and then if you have bad apnea, you'll just stop breathing again. Or stop pulling air in. And what happens is these pauses in breathing, or the inability to get air in, because it's really not a pause in trying to breathe, it's a pause in air going in, causes drops in the blood oxygen level, not good for your brain or your heart, and it breaks up your sleep because you have to keep waking up to breathe. Unfortunately, apnea is getting more and more common in society. In 1990, it was estimated in the US 1 in 25 women and 1 in 11 men had clinically significant sleep apnea that was severe enough to cause serious health risks. Now it's 1 in 18 women and 1 in 8 men. As of 2010, it's probably even higher now because obesity is getting worse and we're all getting older. So age and obesity both contribute to sleep apnea in both men and women. Again, well, there's a couple of health risks I want to point out before I show you pictures. We know sleep apnea untreated is associated with a lot of medical problems, including high blood pressure, heart attacks, strokes, cardiac arrhythmias like atrial fibrillation, depression, and just increased mortality, so all-cause death. So, and also increased risk of Alzheimer's, which I'll talk about in a moment. These are some data from some subjects that we studied in Wisconsin that were supposed to be normal, healthy controls. So these are people who did not complain of any sleep problems. But we found that in this big group of control, supposedly healthy subjects, we found that a percentage of them that was a little higher than I would have expected had significant sleep apnea. So they had apnea and didn't know it, but they were otherwise healthy. And we compared, again, their slow wave activity. This is our apnea group and our control group, and they don't look that much different. Again, this is the front of the brain where the slow wave activity is the strongest. But we compared them both in terms of a comparison of the absolute power of slow wave activity and the relative power. And what we saw is that the people with apnea had a loss of slow wave sleep in this posterior part of their brain, sort of back here. And that this loss of slow wave activity locally was correlated with how bad their apnea was, either how many times they stopped breathing per hour, how much they dropped their oxygen level, or how many times they woke up at night. And when we map it into the brain, this is the middle of the brain. The brain, of course, has two hemispheres. So this is sort of the inside of of one half of the brain. And we found that this area of decreased activity could be mapped on to this posterior part of the brain here, which is called the posterior cingulate. And that happens to be the area when you fall asleep that is the last to fall asleep. Now, this was not related to arousals because this was a time of night where there weren't any arousals. We would take a small chunk of apnea-free time. But again, this area looks as if it's the same. The brain usually falls asleep. Each time we fall asleep, the front of your brain falls asleep first, and then it slowly sweeps back, and this takes several minutes to happen. Now I want to keep that area of brain in mind. Now we're going to talk about sleep apnea, and Alzheimer's disease, which is one of the areas that I'm most interested in now, and an area that we are starting to study here at UCI. We know that there are very strong relationships between sleep and Alzheimer's disease. Alzheimer's, of course, involves accumulation of proteins called beta amyloid and tau protein tangles. So these are plaques of beta amyloid and tangles of tau. And Dr. Fedorov, I think, is talking a little later in this series, and he's going to talk to you more about Alzheimer's disease. What we know is, as I told you before, is sleep is really important for clearing these things out of the brain. That's when it happens. And that we know sleep loss leads to decreased clearance of this beta amyloid and increased deposition of amyloid. We also know that when amyloid gets deposited, it disrupts sleep, and you have less slow waves when you've deposited. So it's sort of a vicious cycle. Sleep causes these bad proteins to accumulate, and once they accumulate, that part of the brain can't sleep as well. So it's then a downward spiral. A recent study looking at all the available data has concluded that at least 15% of the risk for Alzheimer's disease is attributable to sleep problems, disrupted sleep or sleep disorders, including apnea. We did 2 studies in Wisconsin, which were published over the last couple years, one very recently. And in these studies, we were looking at groups of adults, average age in their 60s, who did not have Alzheimer's and did not have cognitive impairment, but were sort of enriched for people at increased risk because of things like family history. And in that study, we did brain imaging, and we collected CSF and did neuropsychological assessment. We did not do actual sleep studies, but what was done was some self-report about sleep. And there was a particular subscale on something called the Medical Outcome Sleep Scale, which asked a lot of questions about sleep. And this subscale, which is called sleep adequacy, asked these 2 questions. How often did you get enough sleep to feel rested upon waking in the morning? And how often did you get the amount of sleep you needed? And there was a several-point scale. And what we did was we looked at the relationship between this subscale. We actually looked at a bunch of them, but this was the one that came out to be significant. The relationship between this subscale and evidence for amyloid deposition, either on PET scans, which actually image the brain itself where the amyloid is deposited, or levels in the cerebrospinal fluid, which are thought to be the most sensitive and earliest sign of deposition. And what we found in each study, in each group of people, that poor self-reported sleep, the ones that had worse scores on that sleep questionnaire scale, showed more evidence of amyloid deposition in areas known to be affected by Alzheimer's, either by PET scanning, this was 100 subjects, again, the average age is in the early 60s, or by CSF. We also have started to do some work where we're looking at sleep, using that electrode cap, looking at sleep all over the brain. And what we found is that in individuals whose sleep was otherwise normal, they didn't have sleep apnea or anything else, that those who had decreased activity at the back of the scalp here had more amyloid and tau deposited than those who had a more normal pattern of EEG activity there. Now, we don't know which is the chicken or the egg. Is it the deposition of these proteins that is impinging on sleep, or is it the loss of sleep here that is affecting, that's affecting the deposition of the proteins? But now I want to show you again, sort of compare the effect of sleep apnea. And people with sleep apnea are known to develop Alzheimer's earlier, and people who have Alzheimer's with apnea tend to progress more quickly. And there are now some signs that treating sleep apnea may slow progression, but we don't have data on what happens if we treat apnea before Alzheimer's becomes clinically significant. And what I want to show here, again, this is our slow wave deficit. This is where the brain is not sleeping well. And here is where amyloid deposits first. These are 2 separate groups of similar individuals, middle-aged adults who do not have Alzheimer's or other health problems. The people with apnea show a deficit of activity here. The people who are depositing amyloid start to deposit here. So it sort of creates the question as to whether this is one of the ways that sleep disordered breathing is affecting Alzheimer's, and the relevance is that we can treat apnea. And the way we treat apnea is one of the sort of the classic gold standard is continuous positive airway pressure, which I know a lot of people feel is a nuisance, but it's basically blowing warm air in the nose to keep the airway open, and it is one of the safest treatments we have. We know it can reverse the risks for heart attacks and strokes, and one of the big questions is, can it decrease the risk or the tendency to progress in Alzheimer's? And this is an area that we're going to be doing more research here, so we're going to be recruiting people who don't have Alzheimer's, but to look to see how sleep and other factors may be affecting that. So now let's talk a little bit about what you can do to have a little bit better sleep. So healthy sleep tips. So we'll start with sort of what we call sleep hygiene or good sleep habits. Now, most people are aware of these things, and a lot of people will do them. And if you already are, you know, sort of a perfect A+ gold star person doing all your good sleep hygiene and you're still worried your sleep isn't right, don't worry, because it doesn't mean there's necessarily anything serious wrong with you. It's just that this is where we always have to start. And for people who have chronic insomnia, these rules don't necessarily get rid of your sleep problem, but they allow other treatments to work better. So the first thing is you have to have a regular bedtime and a regular wake-up time. And the most critical thing is to have the regular wake-up time. A lot of times what we do is if we don't get to sleep at night or we're up a lot at night, and particularly if we are retired or don't have to go to work right away the next day, we'll try to catch a little bit more sleep by staying in bed, but that starts to throw the whole thing off. So the one thing you can always reinforce is your wake-up time. That should pretty much be the same 7 days a week. Another thing to keep in mind, sort of on the flip side of this, is that if you're using an alarm to wake up and you need that alarm to wake up, you're probably not getting enough sleep. It's not that every so often you might be sort of on your way to get up and it reminds you, but if you're awakened out of like a dead sleep by your alarm, you're probably a little bit sleep deprived. If you have insomnia, avoid napping, because you want to build up that need for sleep so that you're more likely to fall asleep at night. If you nap a little bit, the drive to sleep will be reduced later in the day. Exercise is really important. I mean, it's important for so much for health in general, and one of the nice things about being in Southern California, since I'm not a snow person, is it's easier to exercise all the time here. We can get our sunshine, which is also important. So bright light exposure during the day, and exercise and activity, physical activity and mental activity is important. I always like to remind people is that your sleep at night problems at night are not just a nighttime problem, it's a 24-hour problem. And what you do during the daytime has a great impact on your sleep at night. So these are tools: good exercise, brisk exercise, and bright light exposure. But you don't want to exercise really early in the morning. I have a lot of my insomnia patients, well, I wake up at like 4 or 5 in the morning, so I go to the gym, because it seems like that's a good time to do it. And that's just reinforcing the waking up really, really early. The ideal time to exercise is neither first thing in the morning nor late at night. My sons used to drive me insane because they would talk to me about how they're going to the gym at 11 o'clock at night. Not a good idea, but they were sort of night owls. So the best time is in probably the late afternoon or later morning is fine too. And again, bright light during the day, and do not expose yourself to bright light or a lot of blue light later in the evening, because that kind of gives a signal to your circadian clock to stay awake. Okay, make sure your bedroom is conducive to sleep. And the biggest thing here is slightly cool in temperature. Bedroom has to be dark, quiet, comfortable, and slightly cool. We go to bed warm and we go to bed cold and we wake up warm. You don't notice it so much here in Southern California, but anybody who's lived in a northern climate can probably relate to, like in the winter, you're freezing to death and you're bundling all the covers on, and a couple of hours later, it suddenly feels like the heat has gone on and the room is a lot harder. That's because the thermostat in your brain turns down its set point during the night. So you want to be a couple of 1/10 of a degree cooler in the middle of the night and towards the early morning, and then you want to be warmer later in the day. And so being at the wrong ambient temperature is very sleep disruptive. So it's very hard to sleep if it's too hot. It's a little hard to sleep if it's too cold, but at least we can pile covers on. So make sure you have layers. This is even more true for women who are post-menopausal. We'll tell my joke of one of my colleagues, who's a man, was once, we were doing a lecture, a set of lectures together, and someone in the audience asked, what is the right temperature for your bedroom to be? And he answered, not to be sexist about this, whatever your wife says. Because women are a lot more sensitive to the fluctuations of temperature, particularly postmenopausally. And if you wake up sweating in the middle of the night, that's normal because you do dump heat, and that's why you want to have enough layers and clothes that wick the heat away from you. Get rid of stuff from the bedroom. The more gadgets in the bedroom, the less you're going to sleep if you're having sleep problems. This is really true of kids and adolescents. They get those that the more devices in the bedroom, the less they sleep. Make sure your bedroom isn't noisy. If anything, use a white noise machine if there's sort of intermittent background noise. So make sure you've got a bedroom where you can sleep, and don't do other stuff in bed that's stressful. And then finally, eliminate factors that are going to interfere with sleep. I like to suggest that if you have problems with sleeping, that you make sure that you have at least an hour before your scheduled bedtime. So if your scheduled bedtime is 10 o'clock, starting not later than 9 o'clock, you should be doing something relaxing, something you kind of look forward to, not too exciting, but just sort of, reading or something, but not paying your bills or cleaning up the kitchen or whatever else. Don't do things that are stressful. Don't take a lot of problems. If you are someone who finds that when you get into bed and you start ruminating and all those things that you were trying not to think about all day sort of crash down on you, what we recommend is more than an hour, several hours before bedtime, and not in your bedroom. Sit down. I usually suggest maybe journaling. Write down all the things you're worried about or stressed about, and what you're going to do about them, and make a plan, and then close it up. Because one of the things that happens is that not only at the beginning of the night, but even worse at like 2 o'clock in the morning, every problem or every stress you have seems like 10 times worse. And it's not because it's the middle of the night and you can't do anything about it. It's because your mood state actually changes. So that wherever, the sort of the half empty, half full glass, you're really on everything is half full in the middle of the night as opposed to half empty in the middle of the night. You're focusing on the negatives much more than the positives. And there's a lot of studies that have shown that sleep loss, as well as the time of night, makes you view negative things more negatively and fail to appreciate positive things. So don't think about problems in the middle of the night, because they're always going to seem a lot worse, because that's what's going on in your brain. That's why your dreams are often, by the way, a lot more full of anxiety and stressful things. We don't, sometimes we have very happy, nice dreams, but those are sort of fewer and far between, because one of the functions of REM sleep is probably to train you to deal with danger. It sort of sets those defensive systems. So don't think about bad things. Don't watch the clock at night. We all we wake up and the first thing we do is, what time is it? And if you're having sleep problems, that's the worst thing you can do, because first of all, you have to wake up enough to be able to tell what time it is. And the next thing is, you never have any positive view about it. It's either like, I've only slept for an hour, I'm never going to get back to sleep, or I have to get up in an hour, I'll never get back to sleep. It's really bad. And finally, your brain actually keeps track of time while you're sleeping. You don't realize this, but it does. And so all these patients come in to see me, and they're like, I always wake up at 3 o'clock in the morning. It's because you check the clock, and you think you sort of unconsciously start really, I wake up at 3, and then it's 3:15. Oops, I was a little bit late today. And so don't turn the clock around. Set your alarm, or get one of those clocks. I have the one. I like the clocks that start glowing, because it starts glowing about a half hour before you're supposed to get up. So if you see it and it's glowing, you can get out of bed. It's like those things they have for kids now, that the kids can't get out of bed until, the smiley face comes on or whatever. We can get those for ourselves too, but don't look at the clock. No caffeine and nicotine as much as possible. I don't forbid people to have caffeine. It's okay to have some coffee in the morning. Some of us can't survive without that, but try not, if you're having trouble sleeping, try not to have it much, not in the afternoon, just in the morning. Try not to drink too much alcohol, because even though you don't think it's causing you a problem, you will have more fragmented sleep starting a few hours into the night when you're drinking regularly. Don't drink a lot of fluids before bed, because if you have to keep running to the bathroom at night, you're not going to sleep. There's no pill to fix that. And don't go to bed too hungry or after a large meal. If you have a lot of reflux at night, you're not going to sleep well. That can be also very disruptive. I'm going to now talk about sort of what we call brief behavioral treatment. Now, those sleep hygiene rules are sort of a starting place, but there are many other therapies that we can do, and these are some of the things that we'll be doing in our sleep center. We have behavioral therapists who are expert in a whole bunch of techniques to help you learn to sleep better, sort of like having a personal trainer for your sleep. But there are some sort of brief things that you can do to start. And brief behavioral therapy for insomnia is 4 recommendations. Reduce your time in bed. Now, this seems counterintuitive. If I'm not sleeping and I'm waking up a lot, shouldn't I try to catch more sleep? No, that actually makes it worse. We actually suggest that you reduce your time in bed to fit more the amount of time you're actually sleeping, but don't reduce it less than about 6 hours, not less than 6 hours in bed. Get up at the same time every day. I already told you this once. No matter how much you slept the night before, wake up at the same time. Don't go to bed, don't nap, and don't go to bed unless you're sleepy. So even though you might say 10 o'clock is my bedtime, and you start doing your relaxing activity at 9 o'clock, but you're not at all sleepy at 10 o'clock, don't go to bed yet. Just keep doing something relaxing until you're feeling sleepy, and then go to bed. And don't stay in bed unless you're asleep. If you find yourself waking up and it's not that you're going to turn over and fall back to sleep in a couple of minutes, go out of bed and do your relaxing thing. Do not expose yourself to bright light. I suggest reading under not too bright of light. That's probably one of the best things, because it's time to go to sleep when you can't follow the words on the page anymore, as opposed to television where you're just sort of zoned out looking at it. Plus, it's shining blue light on you. All right, so this spring, soon, we're going to have this beautiful new sleep clinic and laboratory on Berkeley Street, as I mentioned, just south of the airport. We'll be on the first floor, and we're going to be sharing the space, I think, with Men's Health, which you're going to hear about next month, and Executive Health. So for people who are interested, I have a sign-up sheet. We're going to be taking care of the full range of sleep disorders: insomnia, restless legs, sleep apnea, sleep timing disorders, jet lag, so when you go to Europe and back or whatever, any kind of sleep problems will be taken care of. We will have a full range of treatments, including some really wonderful experts on behavioral treatment. We will have sleep studies in a state-of-the-art laboratory or at home. We more and more are doing, most of our sleep studies we do in your own bed at home, all by yourself. We don't come with you. We're there. You can call us if you need something, but we give you some stuff to wear at home. And again, comprehensive treatment, behavioral therapies, medication, respiratory therapies, light therapies, other complementary and alternative approaches if needed. The other thing I want to mention is we, being at UCI, we are also an academic and a research program, and we're really focusing a lot of our research on things like kind of normal and pathologic aging, sleep in relation to a variety of medical disorders. And for people who are potentially interested in participating in research studies, I wanted to let you know about the UCI Consent to Contact Registry, which is that if you are potentially interested in hearing about research studies that you can participate in, you can just go online and enroll. You don't have to participate if we call you, but that way you'll hear about what's going on. And I've left information on the back table about the C2C registry, where we'll be asking people who want to be part of our study looking at how sleep might affect Alzheimerers and aging, and also a sign-up sheet if anybody is interested in getting more information about our sleep program, knowing about when we're opening up, or any other aspects of that. You can just leave your information and we will be in touch. And since we are UCI, this is Peter the anteater, our mascot, and this is a sleeping anteater. Anteaters sleep like this, curled up, and they use their tail as their blanket, and they can adjust it depending on their body temperature, because they drop their body temperature like we do when they're asleep. And so we want to sleep to remember and remember to sleep. And I will now answer questions. Thank you. Right.
Thank you, Dr. Benca. And we do have time for a few questions.
Yep.
I'm going
I
to
think
ask you all to keep it the questions brief so
repeat
we
them
have
too.
time. And repeat.
Yeah, I'll repeat
Thank
it.
you.
So you want to start in the back since I saw your hand pop up?
You talked about eliminating blue light
Yep.
in bedrooms.
Mm-hmm.
You can buy LED and fluorescent lights with different temperatures today.
Yep.
What temperature are you specifically recommending?
You mean like the room temperature or the light? Well, the light, I mean, again, it's more of a spectral thing. Now, you know, the latest thing are these tunable lights. So basically, what you want is more blue light in the morning, and you want more red light at night. And you can even on your computers and other devices get these programs that will change the spectrum of the lighting of that. And blue light seems to be much more important for training circadian rhythms. And again, outdoors in the morning, the light is more in the blue spectrum. So you want to avoid blue light at night, which is unfortunately the predominant wavelength coming out of a lot of our screens, TVs, and computers, et cetera, unless you change it. Mm-hmm. Yes?
Can you learn when you're asleep? Number one. And number two, can you talk about sleepwalking?
Okay, can you learn when you're asleep was the first question. You can't learn new information while you're asleep. You can't get any new information in for it to be put into memory stores while you're asleep. But you are learning while you're asleep in the sense that many things that we learn are sleep dependent. And so the things you learn during the day are consolidated in your memory at night, and you'll remember them better the next day if you've slept better. But you can't put a new memory in while you're sleeping. And the other thing is sleepwalking. So sleepwalking, I didn't have time to talk about, is another one of my favorite sleep problems and disorders, and something we've studied as well. And in fact, using that sleep cap, we find that people who are sleepwalking, the part of their brain that doesn't seem to be quite as asleep as the rest of the brain is not surprisingly their motor system. So the part of the brain that covers movement is less asleep. And there, of course, what we do when we're sleepwalking is we get up and we do things in general that are instinctual patterns. So things that we don't have to sort of think about, like walking, urinating, eating, drive, you know, implicit memories. And even now people sometimes will drive in their sleep or do other things like that, particularly with sleeping pills. So what happens with sleepwalking is some of these sort of deep instinctual parts of the brain, the limbic system seems to be sort of awake, and some of these pattern generators, these motor systems are awake, and the frontal part of the brain that's supposed to kind of control our behavior is asleep. And that's what we exactly see in the brains of people who tend to have sleepwalking. And sleepwalking is more common in younger people. It sometimes persists into adulthood, but a lot of people sort of outgrow it because young people have so much deep sleep, and it tends to arise out of that deep, slow wave sleep. I'm going to sort of try to go to the back there. Yep, you. Yeah, you. Right. Okay, long-term studies of the effect of taking sleeping pills in general. The newer sleeping medications, I think, including probably extended release Ambien and some of the other newer drugs, azopiclone, which is Lunesta, and some of the other, and trying to think what else. Some of the other ones that have come out recently have been tested for longer term efficacy, like do they help you continue to sleep at night? And for the most part, they will. But there are some studies that have come out, and some people feel that there are some, there are risks of taking these pills long term. I think the American Academy of Sleep Medicine just came out with some guidelines that basically found that at best they would weekly recommend sleeping medications and that in some cases the risks outweigh the benefits. But they aren't, and sleeping pills, particularly longer acting ones that will build up in your system, can cause cognitive impairment as well as problems with balance, and certainly at night they can cause problems with balance. Some of the newer sleeping pills also can cause you to have sleepwalking episodes or do other kinds of things in your sleep you won't remember the next day. So, with that said, do I prescribe sleeping pills? At times, yes, but on the other hand, how should you treat a sleep problem? The sleeping pill is the last thing you should do, not the first thing. There are behavioral approaches first that can be helpful, and in general, the evidence suggests that people who do behavioral therapies, those will work just as well or better than sleeping medications without the side effects. So we like to always recommend starting with behavioral approaches first. But some people do need sleeping medications, and they can be used safely when monitored properly. Yes, we'll start here.
Two quick ones. On the pictures that you showed with the adult and the baby with that thing on your head, if you do a sleep study, do you have to have a sensor taped to your upper lip? And secondly, what do you think about melatonin for helping sleep?
Okay, so a sleep study in the sleep laboratory, we can monitor a lot of aspects of how your whole body's functioning at night. So we do put electrodes on the scalp. We don't necessarily give everybody a cap like that. We often do less electrodes for clinical studies. We do have a probe near the nose that's measuring airflow. We put belts around the chest and abdomen that are measuring respiratory effort. We have like a clip-like device on the finger that's measuring oxygen level. We have other leads measuring motor activity, the electrocardiogram, et cetera. We can, sometimes measure, 30 or 40 different signals. If we do the cap, it's another 256 just for the electrodes. In home studies, we do a lot less than that, but we do have to kind of check your breathing and your position and a few other things. And then the second question was melatonin. Okay, so melatonin is really an interesting substance, and a lot of people will use melatonin. Melatonin is something that your brain produces at night when it's dark. So it has what we call a circadian rhythm. It can only be produced at night. So if I put you in a dark room in the middle of the day, you're not going to make any melatonin. On the other hand, if I come in the middle of the night and I shine a bright light on you, you'll stop making melatonin. So melatonin is what tells our brain how long the day is, because we secrete less melatonin in the summer when the days are long, and we secrete more melatonin in the winter when the days are short. And melatonin, one of the main functions of melatonin has actually been to regulate breeding. So that's why we have spring lambs and spring horses, animals are born in spring. In fact, humans were very seasonal breeders as well. Humans used to be born in the springtime because, again, most life forms are at more northern latitudes because most of the land mass is north of the equator. And unless you're at the equator where the days and nights are of equal length, you're having to deal with seasonal changes. So that all stopped about 50 years ago when electric lighting became more widespread. So now humans have sort of lost that seasonal rhythmicity to some extent. So melatonin tells your brain that. Now melatonin also tells your brain what it's supposed to do when it's dark out. And sleep is one of those things. Now if we give melatonin to a rat, which is normally active in the dark, melatonin will wake the rat up. But because that's what the rat is, it sort of governs the behavior that goes on at night. Some people find melatonin rather sleep-inducing. Some people doesn't seem to necessarily put them to sleep, but it does reinforce a circadian rhythm. And if you're, particularly for people who can't get to sleep at night and then they can't get up in the morning, taking melatonin several hours before bedtime is probably not a bad idea. The problem is that when most people take melatonin, they take it late at night and they take more than they need. You just really need a very small dose. And it can be helpful for things like jet lag and shift work. And it's pretty safe for most people, so that's why a lot of people will take it. Yes?
I have 4 quick questions.
Yeah. Well, protein doesn't get into your brain. It's how much protein you should eat so it doesn't get into your brain. So you don't actually get protein into your brain. You get amino acids. Are you thinking about tryptophan and sleep?
I just thought I heard that people that have Alzheimer's are collecting.
Oh, but those are proteins that are made in the brain. They're not from your food.
Okay. All right. And then I've never noticed a weight loss clinic with this sleep apnea clinic. Is there any?
Okay, so that's a very good question. So weight loss clinic with sleep apnea. That would be an important thing to have because a lot of times sleep apnea is related to being overweight, and the problem is that when you're not sleeping, it makes it harder to not eat what you know, it sort of stimulates your appetite, so it's sort of a vicious cycle there.
Okay, so the weight loss would help a person not have.
Right. What weight loss, if you have apnea that's largely attributable to being overweight, weight loss is the one curative thing. There are other treatments that we can have as well. I'm going to let a couple other questions and we'll come back to, yes, in the back.
So you described what happens when a person goes to a sleep clinic,
Right.
taking the electrodes,
Mm-hmm.
something by their nose, something around their
Mm-hmm.
section. How does a person who's having a problem sleeping fall asleep with all that?
Ah, good question. So one or two things happens. Well, first of all, we don't put people in sleep labs right now for insomnia. That's not an indication necessarily to have a sleep test. We put people in sleep labs, particularly the in-lab studies, if we're thinking about a serious sleep breathing problem, where they may also have other medical problems like heart disease or lung disease that we need to check on, or they've had a stroke, or they have an arrhythmia. There's some other disorders where we're trying to decide, do they have a seizure disorder, or is it a sleepwalking episode, or some abnormal movement disorders. And so for a lot of those disorders, we don't have to get a perfect night of sleep. And it is really, really rare that somebody doesn't sleep at all in the lab. Usually we get enough sleep, and what we usually do, at least in the labs I've always worked in, is if you really don't sleep, we give you a do-over. And the other thing is that, ironically, sometimes people sleep better in the lab than they do at home, particularly with insomnia, where oftentimes people are conditioned in their home environment that they don't sleep well. It's sort of like the opposite of people who do sleep well at home and then they go to a strange environment and can't sleep. And it's usually kind of pathognomonic where, like sometimes a couple times a year someone will say, I got the best night of sleep ever in the lab, because they're sleeping terribly at home, because the pressure's off, because we don't expect people to sleep normally in the lab. And that gets into some of sort of the kind of conditioned or behavioral factors that can affect sleep. So it's a good question. Yeah. Over here. Yes?
The cognitive impairment that you talked about that comes from some of the sleep medications,
Mhm.
is that temporary? Does that go away with itself?
Yes. Usually the cognitive impairment. Okay, so the question is, if you're having cognitive impairment related to sleeping medication, will it go away once you stop the medication? And in general, the things that we would normally see, yes, they go away. And things like trazodone. Now, trazodone and a lot of other pills, medications that are used, and these are what we call off-label because they're not approved for that indication, but that's one of their side effects. So they're used a lot for that. So some of the sedating antidepressants like trazodone or mirtazapine or gabapentin, which is an anticonvulsant, and some other antidepressants like amitriptyline are often used for sleep, even though they're not indicated for that because they're not controlled substances or they're non-addictive. Now, a lot of those drugs have kind of long durations of action, so they can hang over a bit the next day, and it's sort of that hangover that makes you feel sluggish and like you're not functioning very well. Again, if you stop them, that will go away. And the other thing is that sometimes if you stop them abruptly, you can have what we call rebound insomnia, much like a regular sleeping pill, which is that you sort of have worse sleep than you would have if you weren't taking them. So just because, even Benadryl, which a lot of people will take over the counter, if you're taking it regularly and you stop it cold turkey, your sleep will be very disrupted for a while till you sort of get over that. So even a non-addicting or a non-controlled substance can cause some withdrawal effects if you stop them quickly, yeah.
We have time for one more
One more
question,
I'll
doctor.
be here then if people want to talk. Symptoms of sleep apnea: snoring, gasping, witnessed apneas, daytime sleepiness, frequent urination at night, morning headaches, cognitive impairment during the day. Could be insomnia as well sometimes, feeling like your sleep isn't restorative. Can be, or no symptoms at all. Can be no symptoms at all. In kids, they can be just hyperactive. Yeah. And
Very
I'll be
much.
here if people have more
Dr.
questions.
Benca will be here to answer a few more questions.
Sure.
Thank you, and we'll
all.
see you in October.